What is the source for amenorrhea? There is not enough source, but this is the new guideline. I'm very happy about it because it has come in 2020 and it gives you more clarity about the sexual development. It gives you more clarity about choosing the amenorrhea questions. This is Mayer-Rokitansky-Kucher-Hauser syndrome. This is old guideline. As you can see, this is 2012 guideline and 2013 guideline of outflow tract disorder. If you read all these three guidelines, you can solve maximum number of amenorrhea questions. I have taken some points from strategy also to make you your understanding more better about it. So what is amenorrhea? Amenorrhea is primary or secondary. Primary means not started period by the age of 15 or no secondary sexual characteristics by the age of 30. Secondary means absence of menstruation for 6 months in a previously regularly menstruating woman or for a time period of 3 cycles in a woman with longer irregular cycle. So either 3 cycles or 6 months for regularly menstruating women. And here this is 15 and 13 years. Now, for amenorrhea questions, first of all, you have to understand that for a woman to get period, what is required? The required things are the normal hormone, the normal hypothalamic pituitary axis, and the normal uterus, normal outflow, normal uterus, normal vagina. If all hormones are normal, if uterine cavity endometrium is normal, if outflow tract vagina is normal, then only she can menstruate. So first we'll talk about hormones and then we will talk about the uterus and outflow tract, which could be sometimes the reason of primary amenorrhea. So if you see here, hypothalamus, it will secrete GnRH. It will go to pituitary. Pituitary will secrete FSHLH. It will go to testes and ovary. Ovary will secrete estrogen. And this is how it will give the positive and negative feedback. So if this axis is intact, then only she will have her periods or she will not have amenorrhea. So if you see in hypothalamus, sometimes they will give you Kalman syndrome. This will be a cause of primary amenorrhea because this is the defect in the migration of neuron from olfactory bulb to the brain. That's why whenever they want to give you Kalman syndrome, they will always give you difficulty with smell. She cannot smell, anosmia. So that is Kalman, where there will be no GnRH, no FSHLH, nothing. This is completely blocked. So you will find that there is no period. That is primary amenorrhea. But hypothalamic, there could be secondary causes also, like trauma, tumor, like anorexia nervosa, bulimia, all these things are going to affect the hypothalamus, leads to secondary amenorrhea. The same thing with pituitary, it could be primary, trauma, tumor, infection, or it could be secondary Sheehan syndrome after postpartum hemorrhage. The same thing with ovary, primary will be Turner's, where genetically abnormal, the ovaries are not working, so no hormones, nothing, so she cannot have periods. And the other could be secondary, which could be primary ovarian failure, radiotherapy, chemotherapy, damage to the ovary in some way. So that way it will be primary or secondary amenorrhea. So everything, all these three things can have primary and secondary amenorrhea. Only you have to understand that different names for different things and the clinical picture and hormone picture will be different. If it is hypothalamic or pituitary, the level of FSH and LH will be low. While if it is ovarian failure, there will be no negative feedback and FSH and LH will be high. It is like if ovary is not working, the pituitary is pushing harder. So it is secreting more FSH and LH to stimulate the ovary. But ovary is failed. Ovary has nothing to secrete. So ovary will not secrete, but still pituitary is trying. So it will secrete more. Am I clear about the hormone picture? If it is coming from up, FSH-LH will be low. If it is ovarian failure, FSH-LH will be high and estrogen will be low. Am I clear about this? So this is all about hormones, how a normal hypothalamo-pituitary ovarian axis is going to give the women normal period. Now, if you see, this is the amenorrhea talk. This is 2019 talk. I already showed you in infertility. This is 2019 talk. If you see here they have again mentioned about amenorrhea. when we used to give exam, we always used to get confused about this. Excessive exercise, eating disorder, psychological stress, these all lead to hypothalamic amenorrhea. And the hormone we think then it should be low because it is hypothalamic, so FSH should be low. But the hormone could be normal. This is the main confusing point. They will give you all this, they will give eating disorder, exercise, and you think they are talking about hypothalamic, and then they give you normal FSH and LH in the lab finding. You get confused. So you have to understand that in the beginning in hypothalamic, there will be normal level and gradually it will become low. So normal level doesn't preclude you from choosing hypothalamic amenorrhea. Sometimes, whenever they make a EMQ of amenorrhea, there will always be one question of hypothalamic. There will always be one question of ovarian problem because they have to categorize it into three. So hypothalamic is their favorite. So if you understand that this level could be normal in hypothalamic, you can easily choose hypothalamic amenorrhea for a woman who is thin, lean, BMI 17 or something like that. They will give you, and you can easily catch up. Am I clear about this? How to choose hypothalamic, even with normal FSH and LH? Because it will become low, but later in the beginning, it will be normal. So sometimes they will give you this scenario to confuse you and to make your life more difficult. Clear? Clear, all of you? Okay. So then comes the Turner syndrome where there is ovarian failure. Whenever they want to give you Turner syndrome, they will always give you short stature. They will never give you a single question of Turner without short stature. Whenever they are talking about short stature, always think about Turner. Then all those things you have to keep in mind: coarctation of aorta and hearing problem and genital problem, renal problem, all this you have to keep in mind. These all you can easily interpret: hypothyroid and this cubitus valgus, webbed neck. These all things are the important one. But short stature is something which always be there in the question. In PCODs, it is the dysfunction of hormone. It is not failure, pituitary failure, or ovarian failure, or hypothalamic failure. So there will be normal FSH and normal estrogen. So you don't confuse PCO with all these things. Then comes we have finished about hormones now, that how you will diagnose hormonal problem. Now we have to understand the development problem, the uterine development and the vaginal development. If that is not normal, then also she cannot bleed. If there is no uterus, how she will have period? If it is blocked, if there is no cervix, if there is no vagina, how she will bleed? So you have to understand that the female genital tract developed from the Mullerian duct. This is the Mullerian duct, right? And this is the Wolffian duct. The male genital developed from Wolffian duct, which is mesonephric duct, and female developed from the Mullerian duct. This is the duct. And the lower part, vagina, lower one third of vagina, and all other things like labia majora, menura, all that developed by urogenital sinus. So a bit about embryology, so for you to make things understand in a better way. Now, if you see, this is from the recent talk, that 2020 talk I told you about. If you see XY or XX, genetics are decided of the baby from the beginning. Now, till 6 weeks, the gonads will be undifferentiated. It could turn into male or female. After that, there will be sex region identification Y gene. The sex region differentiation Y gene is the most important thing. If this is there, there will be development of testes and there will be development of testicular cells, and then it will secrete testosterone. Testosterone and AMH it will secrete. There will be AMH, it will suppress the ovary. Then there will be no further development of Mullerian duct. Anti-Mullerian hormone will suppress the Mullerian duct. So there will be no uterus, there will be nothing. So your gonads is testes now because of the SRY gene. Your gonads is testes. Testes has secreted testosterone AMH. AMH has blocked the Mullerian duct, so no uterus. And then there will be, because of the testosterone, there will be male genitals will develop. Wolffian duct will be maintained. and internal genitalia will develop. Now, internal genitalia means there will be testes, there will be internal organs. But what about external genitalia, which is penis? So, if it will convert into dihydrotestosterone and by 5 alpha reductase, it can work on the external genitalia, then only the external genitalia will be male. If the DHT is not acting by because of any means, either the DHT receptor are deficient, 5 alpha reductase is deficient, or testosterone to DHT conversion is deficient, in all this scenario, the external genitalia won't develop and it will look like a female. It will be a blind pouch like vagina. So this is where you have to understand that internal and external genitalia difference, how they are dependent on different things. Internal genitalia, only testosterone, testes, and Y gene is enough. While for external genitalia, DHT, and it has to act in a proper way to develop the male external genitalia. And if this is deficient, the internal genitalia will be male and external genitalia will be female. Am I clear about this? If you understand this, you can easily understand the androgen insensitivity syndrome. My dear, you have to have Y gene, you have to have testes to secrete testosterone and AMH. AMH will suppress the Mullerian duct, anti-Mullerian. So suppress the Mullerian duct, no more uterus. Testosterone will maintain the Wolffian duct, internal genitalia will develop. But dihydrotestosterone is something which is required to work on the external genitalia. If dihydrotestosterone is not working properly, then external genitalia will be female, but testosterone is there, so internal genitalia will be male. Am I clear now? Okay, great. Now, how you will differentiate? Both these conditions, uterus is not there. Whenever in the question they have given you uterus is not there, then only two differential diagnoses, either MRKH or androgen insensitivity. So if uterus absent, your diagnosis come down zero down to only these two conditions. So how you will differentiate MRKH from androgen insensitivity? In cases of MRKH syndrome, there will be no uterus, but there will be healthy ovary, which will secrete all the normal hormone. So it will be a female with all secondary sexual characteristic. Everything is normal, but she has no uterus and blind vaginal pouch. That's why she is not bleeding because there is no uterus, no endometrium. How to bleed? So only ovaries are there to secrete the hormone, and she will be hale and hearty and healthy because of all female hormone. But no ovary and no uterus and no period. So if she wants to become pregnant, she has to go for surrogacy, borrow a uterus. That is what its significance for fertility. Now, coming to the androgen insensitivity, this dihydrotestosterone is not working. Androgen insensitivity means androgen is there, but it's insensitive. Words is saying insensitive. It's not working. The genitalia is insensitive to the hormone. Androgen insensitivity. Testosterone is there, internal genitalia is male, testes, but the external genitalia is female because it is insensitive to the androgen. That's why she will be that's why she will be a tall, beautiful female with blind vagina and normally developed breast. This is what they give you. It could be of two types, complete and partial. In complete, the breast will be properly developed. Means the testosterone has converted to estrogen in the fat cells. That's why the breast development is there. But the hairs will be deficient because the androgen are not able to work on the peripheral cells. Ultimately, dihydrotestosterone is the one who is working mainly and making you a male. So dihydrotestosterone is not working. So she has a testes, but it is not working on the periphery. That's why she will have a vagina, blind pouch, no uterus, only testes, Good breast development because the testosterone is converted to estrogen in fat cells, and no hairs. So, in one line, if you see, it is hairless, beautiful, tall, female. Hairless, beautiful, tall, good breast development, female. You will label it as female because there is no external genitalia of male and she has good breast development. Testes, whatever testosterone is secreting, is converting into estrogen. So, this is how you will diagnose complete androgen insensitivity. In partial androgen insensitivity, the insensitivity level will be differing. So, there could be hairs, breast will not be developed so much like this. So, they will give you usually like it will be small penis or hypospadias. This little bit development of external genitalia is there, but not properly. Not like female, not like proper male, not like female. So partial androgen, small penis, hypospadias, small scrotum, sometimes incompletely closed. So this is how the partial will be. Usually they give you complete because it is easier to diagnose rather than partial. So this is how you have to differentiate. Sometimes they will give you in questions that the testes are like inguinal hernia. If they are talking about inguinal hernia, always think about androgen insensitivity. Because if they are talking about inguinal hernia, it is nothing but testes in the inguinal canal. So inguinal hernia is always about androgen insensitivity syndrome in the childhood or later or any time. So this is really important for you to differentiate these three things. Am I clear about this? You can now diagnose MRKH and androgen insensitivity. Okay, great. Now here we have discussed about uterus, that you have to have uterus to bleed, to have periods. Now we'll talk about outflow tract. You have to have a proper outflow tract to bleed. So this is vaginal septum, transverse vaginal septum, high, middle, and low. If there is any septum, definitely she cannot bleed. Whatever menstrual cyclical pain, when they give you in question cyclical pain, it is always talking about outflow tract obstruction. So don't confuse cyclical pain with MRKH, which is atypical type of MRKH, which is less common. Always they ask you most common and famous presentation. So in MRKH, always absent uterus they ask you. If they give you cyclical pain, again, they are talking about either septum or imperforate hymen. Only two differential diagnoses with cyclical pain and rarely MRKH. So how to differentiate septum from the hymen? How to differentiate that? Can anybody tell me that?
And septum will be a pinkish bulge,
Mhm.
and the hymen will be bluish
Why?
color
Why
bulge.
it is like so?
It's because in hymen, if it is there, the blood will be protruding through the hymen, giving a bluish tinge.
Yes. And because
The
the
septum
septum
is
is
And
thick.
thicker. Thicker and hymen is
Yes.
thinner, madam. Hymen is
Very
thinner,
good.
so collected blood is seen
Very good.
from outside.
Excellent. Excellent, both of you. Very right. So because septum is thicker and the membrane ultimately is a membrane. So it is a thin one. And septum is ultimately a tissue. So it is a thick one. So if you see here, this is the septum, which is thick, looking pink. And this is the imperforate hymen, which is bulging and looking bluish because the blood collected inside is partially visible because the membrane is thin. So if you see this picture, you will never get confused which is pink and which is blue. Once you have a pictorial things, that it will give you a better impact in your mind and there will be no confusion anytime, even in the exam under pressure when you are in the panic mode. So this is all about all the possibility of amenorrhea. This is the master chart. Whenever a woman come with amenorrhea, you have to first look for secondary sexual character, if it is there or not. If it is there, means hormone is intact. Hypothalamo pituitary ovarian axis is intact. Then only hormone is intact. That's why secondary sexual character is there. If hormones are not intact, then you have to check for the hormone. So you will look for FSH. If it is less than 20 or it is more than 20. If it is less than 20, means hypothalamus is failing or pituitary is failing. If it is more than 20, means ovary is failing. So first of all, always, whenever a patient comes with amenorrhea, your first choice will be pregnancy test. Pregnancy test most important to rule out if she is pregnant. If she is not pregnant, then you have to go for FSH to look for is it a upper cause or it is an ovarian cause. After FSH, you have to look for other hormone, which will be prolactin or the male hormone, virilization hormone. These are the other hormonal parameter you will look for. And at the end, you will go for ultrasound to look for uterus. And if you find the uterus absent, you will go for karyotype. This is how the uh, sequence goes. So you have done the FSH. What you will look for? If it is less than 5, means this is failure up. If it is 5 to 20 means intact, so there is some another abnormal hormone like virilization, like prolactin, like thyroid. If it is more than 20 means it is ovarian dysfunction, which could be Turner sometime, which could be something else. So you have to check for karyotype here. Sometimes they ask you the diagnosis, sometimes they ask you about investigation, what investigation next you will do. So when you get high FSH, you have to look for karyotype to rule out Turner. This is importance of karyotype. If you do ultrasound and you find uterus is absent, you have to again look for karyotype to diagnose androgen insensitivity, which is 46XY. So here is the two role of karyotype. One is for Turner and one is for androgen insensitivity. Because in Mullerian agenesis, it will be 46XX and in androgen insensitivity, it will be 46. Why? If all these things are normal, ultimately you will blame to the vagina. So you will look for uterine outflow blockage, which could be either septum or hymen, or it could be sometimes outflow problem could be Asherman syndrome for secondary amenorrhea. Because if the uterus lining is damaged, definitely she will have no periods. Am I clear about this master chart now? The sequence of investigation as well as when is the role of karyotype. Okay, great. So let us go to practice now. The DHEAS, my dear Priya, will be for the androgen. High androgen means it could be androgen. That's totally a different topic, hyperandrogen. If DHEAS is high means it could be adrenal tumor. It could be Cushing syndrome. So all that things is totally a different scenario. Hyperandrogen itself is a big topic, which there is a talk for that in 2013. You can go through that. Even sometime I posted the recording of that in the group, Telegram group, I think, which was a beautiful presentation. Okay, so now anybody can read these questions. Enough of me talking. Let me see how much you grabbed from the presentation. Anybody can read it?
Okay, ma'am, I'll read.
Hmm.
A 16-year-old girl present with primary amenorrhea. She has normal secondary sexual development. Clinical examination reveals a short, blind vagina. Her karyotype is 46XX. So, ma'am, it will be Mayer-Rokitansky-Couster-Hauser syndrome,
Very
MRKS
good.
syndrome, ma'am.
Very good. Why you think like that? Because
Ma'am, short, blind vagina, and
hmm,
there is no, I mean, it's not talking about uterus.
hmm,
It's normal secondary sexual character is there, which is present with the syndrome, and uh, and karyotype is 46XX.
very good. So all the factors are supporting, though they have not mentioned about uterus, but they have clearly written normal secondary sexual characteristic means ovary intact. Short blind vagina means it support MRKH and karyotype XX. If karyotype XX means it support MRKH. Yes, my dear. Next.
A
Yes,
15-year-old girl. Okay,
Yes,
okay,
somebody
you
else
start.
can read it. Everybody one by one can read it.
Madam, a 15-year-old girl presents with amenorrhea and abdominal pain. Clinical examination reveals a pelvic mass and vaginal inspection demonstrates a pink bulging membrane. Madam, it's transverse vaginal septum.
Very good. So if you see the pink bulging membrane, already it clicked in your mind. It is transverse vaginal septum. Very good, my dear. And they always mention pain in cases of outflow tract obstruction. Yes, next.
Yeah, a 15-and-a-half-year-old girl presents to the outpatient department complaining of absent menstruation. On examination, she has well-developed breasts, but no pubic and axillary hair. Ultrasound reveals absent ovaries, no uterus, no upper vagina.
Yes.
So androgen insensitivity syndrome.
Why you think that?
No breasts and no pubic or axillary hair.
She has well-developed breast and no hair.
Well-developed breasts, but
Yes.
no hair, yeah.
And there is
So, and absent ovaries and no uterus. So it's an androgen intensivity syndrome with a male karyotype.
very good, my dear. Because there is no uterus, only two diagnoses, either mere occupancy Kushur-Hasher or androgen insensitivity. And she has no secondary sexual characteristic, only breast. So it supports the androgen insensitivity. Very nice. Excellent. Now next. Anyone can read it. Anyone can read it, my dear. Anybody?
18-year-old girl has been referred to the gynecology clinic because she has not attained the menarche. Examination reveals the normal development of secondary sexual characters, but short vagina. Plasma concentration of FSH, LH, estrogen are normal. She is 5 feet and 6 inches tall and normal body index. She has just been accepted into medical school and is anxious that she has not attained menarche, although her friends have.
Yes. So what do you think?
Is it same, ma'am? MRKH.
Very good, my dear. Why do you think that?
If our FSH, LH hormone levels are normal,
Hmm.
and she is I go for that.
Nothing else.
Other
Nothing else has been given actually. This is a very poor quality question. In exam, you will not get like this. They should have given you
okay,
something
ma'am.
about the findings. They will not give you only hormones and they will ask you. Because the height is normal, she doesn't fit
Not
into
vagina.
because her secondary sexual characteristics are there, she will not fit into androgen insensitivity. And if the hormones are normal, the
That is
hormone axis is normal. So all in all, it is a diagnosis of exclusion. But believe me, this is a poor quality question, and in exam they give you more clarity. They will always give you blind vagina, absent uterus if they want you to diagnose Markey.
yeah, ma'am. They have given only a short vagina actually.
Yes, yes. So that is
Okay.
how you will be able to
Ma'am,
do.
one doubt I am having.
Yes, my dear.
Actually, this imperforate and septum, I'm still my confusion is not clear. Actually, in imperforate hymen, it is bluish. Is what?
Yes. See,
Can you repeat it?
this is blue, right? This is little
Okay,
bluish,
imperforate
and this is pink, right?
transverse septum.
This is the septum.
Okay, ma'am.
It's
Okay.
pink because it is thick. And if you think membranes are always thinner rather than the septum. Septum is a well-formed tissue, while membranes are thin. That's why the blood is visible through the membrane.
Yeah.
That's why it is blue.
Okay. I got it, ma'am. Okay. Thank you.
Okay? And here it is thick, so it is looking like a tissue, like a bulge, like a normal vagina. Okay, last question.
17-year-old girl comes to the clinic accompanied by her mother. She reports that she has not yet attained menarche. On examination, secondary sexual characteristics have not fully developed. The girl is upset and also says she is being bullied at school for being short. Turner syndrome, madam.
Very good. And why do you think that?
Madam, she's stature is short and secondary sexual characters have not fully developed yet, even at the age of 17 years.
Very nice. So
And no
short,
menarche, madam.
yes, very good. So short means always they are taking towards Turner, and no secondary
No.
sexual characteristic means no ovary. So it is supporting your diagnosis. It is Turner. So very good. So you all are confident about the diagnosis of amenorrhea now and investigation, how you lead the investigation. This is the key. So you all have done a wonderful job.